Hello everyone, my name is Mrs. Tolofa Ayokuni. I'm a warrior and a health coach, the president and founder of World Healthcare Foundation. World Healthcare Foundation is a non-governmental, not-for-profit making and non-political organization established to help the health challenged people, most especially women and youth living with sickle cell disorder and other health-related issues. Welcome to our webinar today. There's a very, very beautiful topic that we want to look at today, something that every one of us all over the world, I'm sure we are waiting for. And the topic is the permanent treatment of sickle cell anemia using gene therapy. And our guest speaker today is Dr. Ugonna Ugochukwu from the United Kingdom, a specialist in regenerative medicine. He is going to throw more light on what gene therapy is all about and its usage in the permanent treatment of sickle cell anemia and beta thalassemia. Why not sit back and enjoy this life-changing presentation with us? Thank you and God bless. Bye.
All right. Thank you, everybody. It's my pleasure to be here with our people today. The condition we are here to discuss about is a very passionate one to each and every one of us. Some of us may know where we are today, but we may never know where we were generations ago, because most of our families and generations have come under the strong bind of this condition. When you have interfaced with one great person, be it a baby, a young person, a minor, an adult, an aged one who has been a warrior through this, you will appreciate the enormity that this is not a one person's cause. It's a cross for all of us to bear. I will start by introducing myself. My name is Dr. Ugochukwu Ogbonna. I practice and work in the UK. I run clinics in London and in Manchester. I also am involved in a drug research, discovery, and development company. So on the clinic side, I see patients. I've been seeing patients from Nigeria, Abuja, and the Enugu clinics of ours. But in the UK, we are working under the government's innovative program, whereby the Home Office will stream and license some practitioners who have innovative skills in therapeutics and in other ways. I happen to be a benefactor of that innovative scheme. What it means today is that you are bringing something new or improving on an existing thing. Sickle cell disorder is inherent in people of Afro-Caribbean ancestry, meaning people whose ancestors originate from the sub-Saharan and the Saharan Africa. Migration through slavery, labor migration, and other forms of migration has taken our people around the globe. Brazil is a recipient of this migratory pattern. The Caribbean countries also are. The Mediterranean countries are. The Middle Eastern countries are. Southern European countries are. If we start mentioning the regions, then when you get to India, it is very endemic. The subject matter of today is sickle cell disease, which comprises of sickle cell anemia, thalassemia of different types, beta thalassemia, alpha thalassemia, gamma, delta. All of these conditions globally are unified as hemoglobinopathy, dealing with hemoglobin. Now, hemoglobin is a protein on the red blood cell, which happens to combine with iron and oxygen carrier. Our audience today, I believe, the ones that are here with us live, the ones that will join us, and the ones that may see this video in the future, will attest with you that hemoglobinopathy plays on the blood level. What I mean by blood level is the blood plane, hemoglobin plane. Oxygen is why we are here today. Oxygen is the most essential thing that drives the cells to be alive. If somebody is swimming and is drowning and is devoid of oxygen for 5 minutes, the major organs in the body will start shutting down. So the Almighty Creator, in His infinite wisdom, made oxygen easily assimilable in the body through the red blood cell. And the essential part of the red blood cell that carries this oxygen is called hemoglobin. Some over 3,000 years ago, before this great migration, our forebearers were all living within the African and the Saharan sphere, Sahara and Sub-Saharan. Something happened. Malaria as a condition transmitted by Plasmodium falciparum mosquitoes came into our sphere, the geographical entity of Africa. With that, the body in its own way, in a way of surviving the invasion of malaria into our body and attendant effects, started mutating. The genes that code for this hemoglobin now started adjusting to a sickled shape. With that sickling effect, mosquito with malaria, Plasmodium parasites cannot survive within the sickled cell. So that became a defensive mechanism. It has already happened for survival. So over the years, even when we move away from that malaria belt in Africa to the temperate regions in Europe or America or Asia, we have already inherited this disorder. So subsequently, offsprings of people that had this gene mutation continued replicating the same gene, passing it on the traits from one family member to the other in generations. Interestingly, they say it takes two to tango. The genetics of this is that one has to, a father will give a pay of this gene onto the offsprings. A mother will also give one to the offsprings. Where you have fathers that have the normal genotype of AA, passing it on to their children, they will just donate A. Where you have mothers that do have AS, there's a likelihood that they could also pass the S or the A to the offspring. Where you have fathers that do have the genotype of AS, small one, and 1S, the sickled one, meeting and having an offspring with a wife or a mother that has the AS, you can see when you crossbreed them, the offspring are likely to have 25% chance of the normal gene, AA. About 50% or double the chances of having offspring of AS, and a 25% likelihood of inheriting 1S from here, from the mother, 1S from the father, and that is SS. That is just statistics. In reality, it may play out the same way. In some other instances, it may play up or down, meaning the offsprings may be more likely to be AA, normal, or AS carriers. But in some instances, more could be. One or more are likely to be SS. It's not just about the A genotype, the hemoglobin A or hemoglobin S. There are some other variants like hemoglobin C and the other ones, the gamma ones. Now, with the sickle cell, we know that this is an inherited blood disorder that affects the globulin gene that transports oxygen through the red blood cells. What about thalassemia? It's basically the same thing. In this instance, what happens is that the body doesn't make up enough of the red blood cells to transport as much needed oxygen as we want. For some time, there are some families that have affected more than others. Since the beginning of the 20th century, around the year 1903 to 1910, much insight were led into this condition. Pharmaceutical companies and drug makers and doctors and pharmacists and scientists and lay people have been working on this condition as it affects people globally. Once in a while, some variations and variants do also occur in the white Caucasian communities, the non-Negroid communities. But it's not as endemic as it is in our own case. The whole world over, Nigeria has the highest burden of this condition, like we know, followed by countries like Zaire, Kenya, Uganda, almost everywhere, Ghana. But coming back to the subject matter, besides the preponderance of the occurrence, we now have gotten to a point whereby our own scientists are owning up that this is our condition, and we have to be on the front line of finding the treatment and the cure to this. The good news is that our people are very religious in our culture, and we believe in our own philosophy that every good thing, everything that happens to mankind, God is aware of it. And we have prayed and fasted in our respective religious groups, and God knows that it's a burden on us, and He did not create us to bear this burden alone, but to carry it to Him. I'm just using this to enlighten our minds. Today, the major pharmaceutical companies have a principle, and it's an investment. Some people will use their shareholders' money to invest in agriculture. A cycle of 6 months, 9 months, 12 months, they harvest their produce and sell and count their profits. Drug discovery and development is a long-term investment, very risky, high financial costs. The research and development budget of companies like Pfizer in a year, at some point in time in the past, used to be more than all the sub-Saharan African economy budgets in a year. Just R&D budget of Pfizer alone, one of the leading pharmaceutical companies, and the rest of them are like that. We all witnessed what happened during the COVID pandemic. They deployed all their resources and arsenals, countries, governments, United Nations, through WHO and the rest of them, looking for a way to salvage mankind. Now that this is our own, is a Negroid one, to what extent has our governments and big businesses and individuals who have deep pockets been able to invest into the funding of these researches? Are we waiting for the Western world to commit their own resources? When we do, and they get the results, they will name their prices and we will have to pay for it. And that is what has been happening over many decades now. I would have assumed that the way we embrace soccer, football, and other sports, the way we embrace other programs, if we know that we are on the front line of this condition, African countries through African Union, sub-regions, ECOWAS, countries, Nigeria, Ghana, Uganda, Kenya, we deploy so much into the researches of this. Make it a national program whereby younger ones in school will get scholarship to study different scientific programs geared into coming to do research on this, or give out grants to research firms. From what I've been saying, is the sickle cell associations, various interest groups that are trying as much as they can as support groups to raise money to support our warriors. It shouldn't be this way. We should be proactive at the national level. Back to what we are saying. How do you manage these cases? This case is such that everybody involved is consumed by it. Science have moved on to a level where they call CRISPR, meaning gene editing. Because this is a condition that revolves around the gene level, the solution has to be genetic, has to be in the genes for you to correct it. What I mean by that, if you are planting your crop on a fertile soil, you will agree with me that the roots are at liberty to grow as deep as they can to get nutrients from the soil. But when you choose to go to a rocky place on top of a rock or quarry to plant your vegetable or whatever the vegetation is, the plants will not have adequate resources to sprout and grow and prosper and germinate, because the rock will not allow it to penetrate to the soil. I'm trying to explain the need for this treatment to be gene-based. Scientists have realized that. So, in articulating a way forward, what they do now is to go to that rock, drill the rock, and pour in some fertile soil and put in the plant. And the plant will do well. And that is when we do bone marrow transplant. Transplanting in pluripotent stem cells, meaning the soil that is healthy, into that rock that is the soil that is affected. Now, with this new way, the transplant and stem cell will supply nutrients to the plant, which is our body, in the bone marrow. We will be doing well. The hemoglobin now will be producing regular round blood, red blood cells that are round and spherical, the way it should be, devoid of the sickled ones. And that carries us for some time. It is still new. Long-term studies of it. I have been privileged to treat some people, a particular lady who lives in America, but a Nigerian origin. She was among the first set of people that went through this bone marrow transplant in Boston, Massachusetts in the year 2000. And she did that bone marrow transplant, albeit the fact that she has to be going back to the clinic every 3 months for checkup and some medications. And she was doing well. After about 7 to 8 years, she had a relapse and went back to her doctors. And they say, yes, the body has finished using the transfused bone marrow that has that stem cell that sustained it. So it means that she has to go through another procedure. That is why I use the allegory of getting manure or fertile soil to pour into the drilled hole on top of the rock. That fertile soil, that plant has finished using that. But is it good? Of course, yes. It has been very beneficial that some people now can live for some years free of it. Some other people are still doing well without any emergencies or relapse. So it is a lot better than where we were before. That's as regards with the bone marrow transplant. There are some other procedures. When we talk about transplants, gene therapy, most of these are what we call ex vivo or in vitro ex vivo, meaning in the test tube outside of the body. Some of them, you will go to a center and the stem cell or blood will be harvested, purified, and sent back into the body. The moment you take it out of the body, it becomes ex vivo. And you transplant it back into the body and it starts working. These are innovations by people, investors' money, who are morally obliged and ethically right in trying to invest their money where it will help mankind. Everybody's effort with respect to this has been geared to saving a life. Any experimental thing or venture in life is a risk. Sometimes it works, some other times it doesn't work. And that's where the government and the regulatory authorities come in, ethical boards come in to make sure that these things are done within guided guidelines that will be more beneficial. Every surgery we undertake is a risk, but there are some surgeries that are just absolutely necessary. In accident and emergency cases, surgeries are very absolute. In congenital conditions where people are born with some structural deformities and other things, surgeries are absolutely necessary. Does it come with risk? Yes, it does. But we can overlook that risk. The benefits of it way outweighs the risk. So, scientists are all bent in the labs and everywhere, looking for the gene therapies that will work. As we speak today, we at Ugo Genetics, with our partner laboratories, we came up with a different philosophy. We came up with identifying what this is. Where does it get into? What role do different organs in the body play to this? Going to the moon, NASA, the US NASA, going to space, they come up with rockets. Even if we do come up with agents, therapeutic agents, that are very much involved in blood production in the body, red blood production, devoid of the sickled ones, how do we get it to the organ sites? How do we get it to the bone marrow? How do we get it to the spleen that is overwhelmed by removing the dead blood cells? How do we get it into the kidney, the liver? So, trying to research and discover or develop and produce vector mechanisms at different levels sometimes becomes a challenge to medical scientists, whereby they now use different methods. They use what we call bacteriophage, sometimes to deliver things to the organ site. The same thing that is happening with hematology is happening in oncology, it's happening in virology, it's happening in other spheres of medical sections. But we have been lucky and successful in getting various vectors that transport the absolute therapeutic agents, which are formula and compounds. One, the one that makes the body produce more blood, red blood cells, the ones that make the body also assimilate to get into the genes to be able to reverse this condition. That is the holy grail of medical research today with respect to this hematology. Reversing these genes is what CRISPR, the gene editing that is ex vivo and in vitro, has been doing, but with challenges, but some successes though. Today, we have been able to make these things non-invasive as well, meaning getting some other vectors that will carry a combination of this reversal factor, this blood stimulating factor, getting it into the body without surgery. How do you do that? Digestion, we know, takes place in the stomach. If you drink water, the moment it touches your tongue, it will pass through many phases down the alimentary canal. The same thing with food. What about medicine? How to enhance it to make sure that once you take that formula, it will get absorbed quickly into the bloodstream, and from the bloodstream, it gets to other sites that you target it to be in. You can bear with me that this is serious proprietary achievements. And because they are proprietary, the details of how those ones work are still proprietary details and information. But we are privileged that above it all, we have been able to formulate a gene therapy, one that is oral in nature. It is not transfusible. You drink it the same way you will ordinarily drink a regular fluid. The duration of the treatment is for 15 days. It's actually for 14 days, but we add 1 day extra to make sure that it covers for compliance in terms of wastages or malhandling. How does it work? For adults, by our way of anatomy and physiology, we've realized that the strength of people, humans, below the age of 12, from 11 to 6 months of age, is different from people 12 years and above. Therefore, this therapeutic agent comes into two segments: for people 6 months and above to 11 years, and some other ones 12 years and to 9900. By the way, we have had the oldest living warriors in their 90s before passing on. Therefore, it is good news. Have we been administering it? Yes, we've been administering it. Albeit the fact that it has been on the condition where you have to give people medications based on compassionate dispensing. Compassionate dispensing, European health agencies, the United Nations, the Food and Drug Administration in the US, they will allow you to give medications on compassionate use when there are no existing drugs that will handle that condition, and where you have the patient in critical condition. Sickle cell warriors cannot predict when the next vascular occlusive crisis will come. They may not say whether it will be the last one or otherwise. We know the fallout of this condition. We have had people, or we do have people, who have stroke as a result of this, who have retinal conditions as a result of this, who have some other debilitating conditions, splenomegaly, enlargement of the spleen, different conditions. This is not where there will be a help coming, and you are waiting for 7 to 15 years of various approvals. During COVID, we witnessed how FDA in America, the British MHRC, the European Union, and every country in the world revoked most of all those holdbacks in terms of clinical approvals and allowed for fast-track approval because COVID was a state of emergency worldwide. And so has our own SCD. I call it our own because we are the first hit. And now it's been brought to the attention of the world that, oh, this is an emergency. We all know that statistics says that between 150,000 to 200,000 babies are born in Nigeria alone every year with this condition. And that we have over 4 million people in Nigeria who are carriers of this threat. Now, do you have to wait for that long? This is something that we are working here with the British government, some agencies, and the NHS definitely will be the first off-taker of this. That is because we are here in the UK. Are we going to wait for them first before our own people? No. Some of our people who are privileged to this, they do come here for this. Some of us send for it. Even the people in the US, they get theirs over there. So, today, through this forum, I will give you the benefit of saying this. This is what it looks like. It is called hemostim or hemocytic reg. This bag contains about 60 cl or 600 ml of that reversal permanent treatment, which we call hemostim. It is a gene therapy. What we usually do for adults 12 years and above, they need to take this 3 packs in a day. 60 cl in the morning, 60 cl in the afternoon, 60 cl in the evening for 15 days. For children, 6 months to 11 years, they also will take it 3 times daily. In their own case, it is 30 cl, which is 300 ml orally in the morning, 300 ml in the afternoon, 300 ml in the evening. For some years now, before we got to this point, people have been taking this. Before we administer, we don't make it a faith science. We make it of empirical science. We have every person, before they take it, their blood specimen will go through HB electrophoresis test, which is hemoglobin electrophoresis test. In Nigeria, there's a particular laboratory called SynLab. It used to be called, before SynLab, before they became SynLab, it was a South African-based laboratory. Pathcare it was. They have laboratories and offices, about 5 or 6 centers in Lagos, Ilupeju, off Town Planning Way, in Festac, in Victoria Land, around Lekki, in Ilori, Ibadan, Enugu GRA, Port Harcourt GRA, Abuja, Aminu Kano Crescent, at the University Gate, Gwagwalada, in Kaduna. They are expanding by the day. This week, I sent a patient on Tuesday. The warrior is in Ilori, Kwara State. I never knew they had a lab there. I got across to the major branch in Lagos. They gave me the contact of the Ilori one. We called, and the warrior went to the laboratory in Ilori on Tuesday. They took her blood specimen and ran the HB electrophoresis test. By Thursday, the report was out and ready. What that report does is that the screening by electrophoresis process will give you a breakdown of various components of hemoglobin in the person's body. It will give you hemoglobin A, which is a normal hemoglobin, the percentage of it. It will give you hemoglobin A2, another variant of the regular hemoglobin. It will give you hemoglobin F, which is the fetal hemoglobin that babies carry. It will give you hemoglobin S, that's the sickled hemoglobin, the percentage of it. It will give you hemoglobin C, which is the other variant of the mutated one. Usually, in the body, hemoglobin A, which is a normal one, is usually in a range of 96.8 to 97.8% in a regular person, supposedly an AA. Hemoglobin A2, the other variant, will give you between 2.2% to 3.2%. Fetal hemoglobin will be around 0 to 0.5%. Hemoglobin S is usually around 48. It's usually 0 to 0.5. Hemoglobin C is around 0 to 0.5%. When we do these pre-treatment tests, we don't conduct it. We are not a laboratory. We will send anybody, the patient, go to this lab. Why do we insist in Nigeria of that same lab, which used to be PathCare? Because their reports are very full of integrity. They don't use expired reagents. They don't cook up reports. We are not here to trash our medical system. But some of us, realistically, we know that in Nigeria, sometimes these laboratories do cut corners. Besides SynLab, which is open to the public, you have Shell Clinic Laboratory in Port Harcourt, only open to Shell staff and their family members. The other one is Julius Berger Laboratory in their clinic in Abuja and maybe in Lagos. Since it's not open to the public, we ask people to go to SynLab to run that test. And that test doesn't cost much, as money is very difficult to come by. As of this week, which it has been for some time now, it has remained 13,800 naira for that test. So reasonably, it's affordable. Once we have that test established, we know where the patient is before treatment. Treatment lasts for 15 days. Day 1, day 2, day 3, day 4. This gene therapy, by day 4, you see that patient no more, the threshold of red blood cells devoid of the sickled ones becomes so much that the patient can now withstand most symptoms. The patient continues, no more crisis as after the 4th day. The patient continues taking this until the 15th day. By the 15th day, the threshold is enough to forestall any vaso-occlusive crisis or any other irregularity. Please, let us also pay attention that this is strictly for the gene condition, which is the SS. I have read out the regular reading of AA, a normal blood, devoid of the sickling gene. Let me give you an insight. When you're expecting 96.8 to 97.8 for a normal HbA level, and somebody goes into the lab and comes out, instead of 96.8, comes out with 2.4. 2.4 as against 96 to 97. That tells you that that person is just moving around by the grace of God. And you look at the HbS that's supposed to be 0, meaning non-existent, to 0.5. That person comes up with 48. That is very hard. You look at the C that's supposed to be 0 to 0.5. The HbC, hemoglobin C, is 45.1. So in totality, that person has sickle percentage of about 93.1 as against where it would have been 0. I'm just using this one that took this test, if you would, just 3-4 days ago, to compare with other ones we've been doing, and none of these people will come back relapsed. By WHO standard, you cannot shout hooray, there's a cure. Cure by WHO standard means that not only would you have reversed this condition, you would have also corrected every other condition that this underlying one has affected. Things like priapism for boys or men, things like avascular necrosis, which is more of an orthopedic condition, things like enlarged spleen, different other things, stroke. Would you have corrected or treated each and every one of these people of these other side conditions to say that you have gotten a cure? No. So technically, that's why we maintain that, yes, this thing has come out very great. Nobody has had a relapse for some years now, since the treatment or the formulation has been built together with the reversal factor. Before then, yes, warriors will take this and they will feel good and feel okay for some months, and down the road, then they may have a relapse, but not as frequent as before. Scientists went back into the laboratory and now went on to achieve that reversal factor that actually drives it in to the genes and corrects that imbalance, which is what CRISPR or gene editing has been trying to achieve. So while gene editing is achieving that at the CRISPR level in bioengineering, genetic engineering over here, which is regenerative medicine using stem cells, have also been able to achieve this directly into this. Bear in mind that what we are talking about is stem cells. What are stem cells? Stem cells are those basic precursor cells that grow to specialized cells of various organs and systems in the body. So a stem cell is like getting your sand to your building site. But whether you are using it to mold blocks, or whether you are using it for plastering, or whether you are using it to mix the concrete, is a different thing. Those ones now become specialized use of the sand in foundation, in block molding, in plastering. I'm just using this to illustrate, basically, so that everyone will be able to understand what I'm trying to explain. I'm not saying that stem cells are sand, but I'm saying that stem cells are those basic basal cells in life that can be turned into red blood cells, white blood cells, cells of the brain, which we call neurons, cells of the bones, which we also have some other osteo names. and different cells of the body. But putting stem cells into the bone marrow and programming those stem cells to keep turning, because the nature of the bone marrow is from where blood is formed. And that is what this gene therapy has successfully been able to achieve. Medical information is a privileged one. It's not something without consent that benefactors or warriors who used to be warriors and now out of the waters, most of them, people are commending them. I receive calls from different people. People call from Nigeria. Is that Dr. Bona? I said, yes. He said, oh, I'm so and so person like this. I was in a function. Somebody gave testimony that the son or the daughter was treated of sickle cell, and that you said that it's not a cure, but it's permanent treatment. Please, can you explain to me? I will explain. He said, well, somebody like that who told me about you gave me your number for the past 2 years since the son went through this treatment. He has been as normal as ever. I have received calls from people telling me that this person they know who has been sickly most of the time, all through their secondary school, university years, and the rest. Everybody around them know that. They now see this young man in nightclubs, partying and drinking alcohol, and it's looking different. Please, can you explain to me? I said, yes, the blood is a central factor in the human body. Every tissue, every organ, every system, the entirety of human body is made of red blood cells. That's what feeds the tissues and the organs with nutrients and oxygen. The most important thing today we are talking about is oxygen. We are here because of oxygen. I'm sure almost every family that is been there with a warrior knows that oxygen depletion triggers the polymerization that leads to this crisis. So if you can send oxygen and nutrients to underneath the skin, you will notice that the skin color, the pale color of some of the warriors, after 4 days of treatment, by the time they've done 15 days, you will not, without anybody telling you, you will know that this is different. We have had one other man in Nigeria, a senior advocate that everybody knows his name, brought the daughter and said, Doc, I'm going with you. If this thing doesn't work, I'm taking you to the Supreme Court. I said, Honorable, well done. We are not going to Supreme Court. We are not even going to Magistrate Court by the corner. What do you want? He said, please, it's not even about going to court. I want my daughter to live. I want to see my grandchildren through her. We laughed. He said, how do you convince me? I said, okay. You have your money? He said, yes. I said, hand this money over to this priest. He said, I don't know the priest. I said, go to him and say that a particular doctor, the priest I'm talking about is a Monsignor. He doesn't know me personally. But there is no man of God who will hear about this that will not step in. Hand the money over to him. Whether it's a check or cash, he will agree that you will tell him after 15 days how your daughter is feeling, whether he should release the money to this doctor. He said, okay, are we going to go that way? I will not do that. I said, go ahead and do that to buttress your point. I treated the daughter. After 15 days, he went to the priest and said, priest, I came here with my daughter. That thing I came up the other time, you were laughing. Did the doctor agree? He said, yes. The doctor, please, I want to go and pay him. And in return, do you have anybody from your parish who doesn't have the money for this treatment? I would promise my God that I will treat as much people as I can based on my means at any point in time. Let me start from your parish. The priest couldn't believe it, nominated somebody who is indigent for treatment. And that's how that young boy went through the treatment and is doing quite well. So these cases we are talking about has been consistent. Medical science in the old time till today, hospitals do not advertise. Architectural firms do not advertise. Law firms do not advertise. But referrals and satisfied patients do the needful. They tell people. Doctors, you go to a doctor who will now tell you, I know where this treatment can be achieved. Go to this place. They will give you what they call referral notes. Among doctors, we are sensitizing each other. But the global game in pharmaceuticals and healthcare is such that some of these things are handled diligently until such a time when it will be in the open domain. But are people assessing these treatments? Yes, they are assessing it, especially under compassionate use. But the good news should come to our own people, the endemic nation of the world or center of the world. When you hear stories of families who have gone through this, the other day, a woman told me that her son, the woman came to UK for treatment on another thing entirely, and told me that her second son is a warrior. Her first daughter is a warrior. I said, okay, can they join this webinar today? She said she will try and convince them that the son doesn't want to hear anything about treatments of any sort. That the only treatment he wants to hear is bone marrow transplant. I said, okay, which is very good. But let him also know that for his age, he has graduated from university. He's living and working in Abuja. So his age may not be the right candidate for this bone marrow transplant. Even when it is, to get a sibling to donate the bone marrow becomes another thing in terms of tissue typing. We discussed, I encouraged her to convince the son to at least tune into this webinar today. He may hear one or two words, and if he now needs further clarification, he can always reach us, either through the organizers of today's webinar, the World Health Foundation, or through to us. So those are the news I must bring to our people today. There are many. That boy's apathy towards treatment of any sort is based on his experience. We have been hearing stories, different versions of people's experiences. People have been made to do things as if it's a ritual and not a medical treatment when they are trying to fight for their lives. You don't blame them. Anybody in their positions could be pushed to this. But what we are saying, even over here in the UK, in America, in the whole of Europe, everywhere, please always ask for medical guidance. Although you may say that what is available in the medical platform may not be sufficient, yes, but it is better than going to complicate issues with some other unknown, unverified treatments. We benchmark ours with scientific proof. That is why Lab today, Pathcare used to be South African owned laboratory. They were in Nigeria doing very well. The biggest lab in Europe is called Lab. It's out of Holland and Germany. They came and bought out the Pathcare because they know that Pathcare has so much good credentials in Nigeria and elsewhere. So they bought out Pathcare and now they branded it their own name, Lab. When you go to Lab, I'm not advertising for them. I don't know anybody there. I'm not a shareholder. When you go to Lab, each of their reports is as good as you going to Schlumberger for oil prospectors, people who are into geology and petroleum industry. everything that comes out of them has full integrity. So if we are dealing with human beings and you want the truth to be there, in what we call global best practice, we start with that empirical evidence. And 6 months down the road, we run the post-treatment work. Why 6 months? You and I know that at birth, from inception in the mother's womb, even the warriors, their genotype is already SS or SC or AS in some instances. But the first 6 months in life, their blood type is that of HbF, hemoglobin F, which we call fetal hemoglobin. It has affinity for oxygen, so it draws oxygen from the mother. And after birth, it remains like that. So they don't have crisis in the first 6 months of life. In that way, HbF becomes what the babies feed on. Until after 6 months, if you then go to test them, their blood would have had good density. So when we treat patients, that first 6 months, if you try to draw the blood to measure the HB electrophoresis, some of them do not have enough density, but after 6 months, they have density, and the reports will come out. You compare it to the one before treatment, and then. So it's an empirical evidence. It's not like the doctor is sending you to the lab. You can walk down to the lab and do it independent of yours. We have had one woman somewhere in the east of Nigeria, to be precise, Owerri. We treated the daughter and asked her to come for post-treatment tests. That was even before the reversal factor became part of today's hemostim. Yet she went there before because the daughter had malaria and she wanted to test for malaria before treatment. When they took the blood specimen, she said, okay, instead of just using the blood specimen for malaria test, please also run for electrophoresis test. And they did. So sometimes you see results before the 6 months, but even at that, at 6 months, we want to run that one and have the full complement of the blood spectrum in terms of electrophoresis. So that will tell it, you can read it when it's like that. The computer will just tell you, with this percentage, this person has heterozygous sickle cell condition, which is HbSC, or this person has sickle cell anemia, which is AA, or this person has beta thalassemia. So we will always encourage those before treatment and post-treatment. And that's as far as it goes. So this is more of an interactive session. Nobody knows it all. Every family, every warrior that has gone through this has built on a big catalog of experiences and knowledge and insights into this thing, much more than even the clinicians. There are some doctors that never saw a sickle cell patient all through their careers and they've retired. Today, as we speak, depends on what part of the world they are practicing in. Likelihood is that the ones in the Western Hemisphere and the ones in the Northern Hemisphere may not have come across a sickle cell warrior. But some of us that come from the endemic areas originally, no matter where we are, we do have insight into this. We know neighbors. We have classmates in primary school and through secondary school and uni who may have been a warrior at some point or the other. So that's why our passion and our desire and our own contribution to mankind by the grace of God is to make sure that we relieve a lot of people. On the social platform, do I know families that have lost so many people? Oh, yes. When I even hear moonlight stories in my own family, I can tell you that I'm almost certain that what used to cause a lot of infant mortality back 50 years ago, 80 years ago, where they will point in one direction and say, that particular family, that woman used to have, she had 12 children, none survived. None of them used to live past the age of 12 or 3 or 7. If you put medical history and family history and look at some of the ones that are there today, if you exhume their bodies to do post-mortem, you'll be surprised that this thing has claimed a lot. And we attribute it to different reasons. Some of them diabolical, some of them ancestral or deity, or one thing or the other. But science is opening our eyes and our will to follow the global best practice and bring positive reports to our lifespans and our lifetime. Thank you very much. I know that we'll be entertaining a lot of questions. What I have just done is to scratch the surface. So please, let's dig deeper and get questions and interest. Thank you.